Perfect. Good morning or hello, everyone. I am Ava-joye Burnett. I'm the moderator for this very special podcast series. It's called A Journey for Women of Color by Johns Hopkins Medicine, a woman's journey podcast, Insights That Matter. Now, as a news reporter, I know the importance of trusted sources of information, especially when it comes to our health. And so that is why I am so incredibly excited for this opportunity to moderate this podcast. And this series, it's a 3-podcast series with information on health issues of importance to women of color. And these 3 topics include triple negative breast cancer, sickle cell anemia, and diabetes. And these podcasts will air each week. So in the first podcast, triple negative breast cancer and women of color, I am joined by Dr. Olutayo Sogunro. Hello, doctor.
Hi, how are you?
I am great. I am so excited to be here with you. Dr. Sogunro is an assistant professor of surgery at the Center for Breast Health at Johns Hopkins Howard County General Hospital. Thank you so much for being here with us today. And in preparation for this podcast, I just started to do some research, and I am excited for you to answer questions that so many women have. I realized that I didn't have answers to many of these things, even though these are topics that we talk about often. We hear the buzzwords in the media. So thank you so much for joining us for this. You know this, but a little bit of backstory here. Black women's overall rate of getting breast cancer, it's actually lower than white women, but the outcome for Black women, it tends to be worse. And Black women seem to be more likely to have what is called triple negative breast cancer, which accounts for about 10 to 20% of all breast cancer, Dr. Sogunro. So I just want to talk to you about all of these things that people might be wondering about triple negative breast cancer. First of all, what is this disease?
Great question. So when we talk about breast cancer, it's important to know the 2 most common types of breast cancers are invasive ductal carcinoma and invasive lobular carcinoma. Within those types of cancers, we also evaluate the type of receptors on the tumor cell. So the receptors sit on top of the tumor cell and allow the tumor to catch and use certain molecules to grow. The most common receptors that we find in breast cancers are 2 hormone receptors, so estrogen and progesterone receptors, and 1 protein receptor called HER2. So any given patient can have a combination of those receptors. Everyone is a little bit unique. Some have 1, 2, or 3 of the receptors, or none of the receptors on the tumor cell. Triple negative breast cancer is a type of breast cancer that is absent of the 3 receptor types. It lacks an estrogen receptor, lacks a progesterone receptor, and lacks that protein HER2 receptor.
And when you say receptor, it seems as if a receptor could be a good thing. What does receptor mean?
Great question. So a receptor is a molecule that sits on top of the tumor cell, and it uses things that are flowing across in the bloodstream to grow. So if something has an estrogen progesterone positive receptor, that means when estrogen and progesterone are going through the bloodstream, the cancer uses that to grow. So why that could be a good thing is that we actually have medications to target that. And we'll talk about that a little bit later. But receptors are just an inherent pathological aspect of the tumor.
Okay, understood. So why is this cancer different from other cancers?
It's different because it is very aggressive. It's one of the most aggressive forms of cancer, which means it's faster growing and has an overall poorer prognosis compared to the other types. A patient who is ER/PR positive, for example, has a more favorable prognosis than a patient who is triple negative. Now, the reason why it's really important to understand why it's so aggressive is that these patients tend to relapse a lot after standard chemotherapy. Compared to patients who have receptor positivity, a lot of these patients can have a high frequency of spread to the lungs, liver, brain, and overall, the prognosis is significantly worse than the other subtypes. When we talk about life expectancy in cancer research, we talk about overall survival. We use that as, with this tumor type or with this diagnosis, what is your overall survival going to look like? We look at this in 5-year periods. So you might hear a term to say like the 5-year overall survival rate is. When we talk about all breast cancers and all stages, okay, all women, all men, all stages, we are looking at an overall survival rate in 5 years of greater than 90%. So that's pretty good, right? You would say of all breast cancers. However, that's looking at all the subtypes. When you break it down to just triple negative breast cancer patients, so triple negative breast cancer patients, all stages, at 5 years, the overall survival is only 77%.
Okay.
Now, when you break that down into stage, so when we talk about stage, we take into account different factors. We take into account the size of the tumor. We take into account the lymph node status, because cancer can spread to your lymph nodes. And then we take into account any distant spread, or you might hear the word metastasis, okay? Metastasis means distant spread. That means outside of the breast and the lymph nodes. So each of these factors combined allow us to stage breast cancers from stage 0 to stage 4. Stage 4 means distant spread. It's the highest stage that you can have, okay? Has the worst prognosis.
And what does stage 0 mean? Does that mean no spread at all?
So it means no spread at all, but it also means in situ disease, which means that the cancer is still within the cell. It has not passed the cell membrane, okay? It's still very, very localized. Basically, you go from 0 to very, very localized all the way to 4, which is distant spread. When you have a cancer that is very localized, you are either a stage 0 or stage 1. When the cancer has spread to the lymph nodes, so we call that regional spread. So it's not distant, it's still in the same region as your breast. Those are usually stage 2 and stage 3 cancers. Mm-hmm. And then when the cancer has spread outside of the breast and lymph nodes, and that would be a stage 4 cancer. When you break down triple negative breast cancer per stage, when you have localized disease, yes, the overall survival is not significantly decreased from the other types. But when you have regional spread, the overall survival is down to 65%. And when you have distant spread, which is stage 4 spread, in 5 years, the overall survival is down to 12%.
Oh my goodness.
Yeah.
So we're going from, I just caught the middle figure where you said 65%. Does that mean 65% of the people who are impacted survive?
At 5 years, if you have regional metastases, so that means you have a stage 2 or 3 triple negative breast cancer, at 5 years, there is about a 65% overall survival rate.
Understood. And so when you go from that to a stage 4 level of cancer, where you have a 12%, is what you said?
Correct.
These are significant numbers. These are major disparities.
It's a very aggressive disease, and that's why we're talking about it. That's why we need to know about it.
Oh my goodness. So we just talked about life expectancy. I am curious about how quickly does this spread?
There's not one specific figure, right? You can't say, triple negative breast cancer is going to spread in 32 days. It doesn't correlate that way. However, it is very aggressive and very fast, and usually untreated can spread in a matter of months.
So we're talking about the impact of this disease on women of color, particularly Black women. They're more likely to have worse outcomes. We mentioned that this is an issue that affects many women. More white women get this disease than Black women. So why is it that Black women are more likely to do worse with this disease?
As you can tell, I'm a big numbers person, and I think that it's really important that when we talk about some of these disparities and talk about even just how impactful a disease might be, it's really important to understand some of the numbers for incidence and mortality. So for just the audience, most probably know this already, but incidence is a number of new cases per year. For breast cancer overall, according to the CDC, overall, the breast cancer incidence rate for Caucasian women is about 135.2 per 100,000, okay? And I'll break that down a little bit. In Black women, that number is 128.4 per 100,000 women. So it's not a huge difference, right? 135.2 and then 128.4 per 100,000. If you look at Hispanic women, the number is 101.9 per 100,000. And in Asian and Pacific Highlander women, it's 104.5 per 100,000. So on average, all that boils down to a statistic of 1 in 8 women developing breast cancer in your lifetime, which is an approximately a 13% chance of developing breast cancer. Now, the incidence rate may not be very different across the racial and ethnic groups, right? That's why I'm kind of averaging it for you. So you'll hear that term, 1 in 8 women, because the incidence rate is similar. However, Caucasian women, like you mentioned, do have the highest incidence rate for developing breast cancer. But in terms of the mortality rate or death rate, so that's the other thing to understand. The mortality rate is the rate of death for breast cancers. It is significantly different. The death rate in Caucasian women is 19.3 per 100,000 versus in Black women, it is 27.8 per 100,000. So this means that Black women are dying from breast cancer at a rate approximately 44% higher.
Did you say 44%?
Approximately, yeah.
So what is happening here? This is the big question. Why is this happening?
A lot of studies have been looking into what some of these disparities may be caused by. One of the things we have found is that triple negative breast cancer affects young Black Latino women under age 40. More triple negative breast cancers are likely to be Black premenopausal women. And a study out of the Carolinas actually showed that a Black woman is more than twice as likely to have triple negative breast cancer than a white woman. Like you said, why is that?
Yes.
So we're still doing a lot of research, trying to fill in what we call these gaps in knowledge, right? So we're trying to understand this and learn it. We know that health disparities result in a worse outcome for women of color, right? We know that. We don't really argue that. But in particular, we've been looking at both biological and socioeconomic causes, because we can't really blame everything on socioeconomic causes. We want to really try to understand the science behind it. So some of the things that we have found so far is we have found that triple negative breast cancer really represents a class of heterogeneous cancer cells, which means it's kind of a mixed bag, because you can have an invasive ductal carcinoma that's triple negative. You can also have an invasive lobular carcinoma that's triple negative. So it's really like a class of cancers with different biological features that still all end up with really poor prognoses. In African-American women especially, we have found some genetic differences may play a role in the overall poor prognosis. These include some differences in biological signaling in some genes, particularly the P53 and the BRCA1 gene. The P53 gene and the BRCA1, you may also have heard it as the BRCA1 gene. Yes. So these are considered tumor suppressor genes, okay? So these are genes that are really important to helping us prevent tumors from growing. So if you have a mutation or a loss of function in one of these genes, then that would make you more susceptible to certain types of cancers, and particularly with those two genes, breast cancer. We've also found some enzymes, which are different molecules that are active in our body. One is called Aurora A and one is called Aurora B. And we found that those two enzymes are really important in what we call cell proliferation. So basically the growth and the continuing division of the cells. So we have a process called mitosis in our body. So basically cell proliferation, cell migration, which means the cell moving to different areas, and also the cell invading, getting outside of the cell into the tissues around it. These are enzymes that are associated with those processes and have also been studied to have role in the poor prognosis of triple negative breast cancer. So those are some of the biological differences that we found in the genetic role of breast cancer disparities.
And this is not something that one can change, because this is literally how you were born. It's your gene.
Correct. These are some non-modifiable things, but it's really important to understand that in order to be able to get medications and target these things, we have to understand it. So a lot of being able to treat any kind of disease is truly understanding the disease, but also understanding the genetic differences. Why? Because the certain targets for one population may not be the target for another population. Understanding these targets are important so we can actually effectively treat it in everyone. I talked to you a little bit about the biological influences, and some of the things that we've also found are like differences in insurance coverage, particularly a difference in health insurance explained about 35% of the excess risk of death in Black women in a study comparing that to the risk of death in Caucasian and other minorities. Also, some concerns that a lot of women of color have shown is that they feel sometimes that they're discriminated or their symptoms are diminished when they're brought to their physician or provider. Sometimes there's neglect from both the patient and the provider side, but also there's some historical context, right, in terms of distrust and discrimination within the medical system have all been described by patients as to some of the reasons why we are thinking that we're seeing a higher prevalence in women of color.
So those are some of the socioeconomic external factors.
Correct.
What can our society do to improve those things? You talked about I believe you said non-modifiable elements. These are things, your socioeconomic access that can be modified. So what can society do?
when we talk about those factors, right, we're talking about the social determinants of health. Those social determinants of health are social, economic, physical conditions that really dictate the places we're born, where we live, where we work, and all those things have an effect on our quality of life and our health. What we can do as a society is, number one, educate ourselves on that, really understand how some of these factors are intertwined with our health, and also access to care. A lot of these socioeconomic things are environmental. So if you live in an area, you've heard of things like food deserts and other health concerns that can lead to things like obesity. One of the things that we'll talk about when we talk about a list of the risk factors is that obesity is now being considered a risk factor for the development of breast cancer. Having lack of access to care, having lack of access to healthy foods, and controlling obesity, those are some really important factors that we can't necessarily control without environmental help. So definitely looking to have social programs that can help communities that do not have access to care, and also increasing the number of patients that are involved in research, particularly in clinical trials. And we'll kind of get to that in a little bit, but I think that's an important aspect to include into how we can actually change some of these.
Well, let's get to it right now. The diversification of your pool of people who are being tested for certain drugs. Talk about the importance of having representation while studies are being done.
It's really important to have the representation in the studies because we do not necessarily have information that is all inclusive. Historically, a lot of the scientific studies that we've done, really just in any medical condition, but particularly in breast cancer, have not necessarily included a significant amount of minority women, even down to some of the predictors of lifetime risk. Some of the really good historical models, don't get me wrong, that we use to determine what a patient's lifetime risk of developing breast cancer, they really had majority Caucasian women in them.
Even in this day and age?
So these are historical models. So a lot of these models are several decades old. However, we are working on different models now to definitely be more inclusive. But I'm just letting you know what we currently know, what a lot of science and a lot of medications and a lot of research is based on are studies that were of patients of a particular ethnic background. They did not include a lot of Black and Latino women. So the information that we know on Black and Latino women is really emerging, if that makes sense. We're still trying to learn more about them because in our historical models, we weren't included. A lot of those things are trying to be rectified at this time. When we talk about the importance of clinical trials, drugs are targeted based on evidence from clinical trials. There's not a medication that can get FDA approved without it being trialed on a group of patients. You work through a spectrum on the clinical trials. So you have phase 1, 2, 3, and those phases have to be tested in lab models. They have to be tested on animal models, and all those things have to happen to determine safety and efficacy before we could get into human testing. So by the time we get to human testing, if we are testing medications to try and see if we're going to be able to, for example, target and treat triple-negative breast cancer, well, if the patients that are involved in that clinical trial are predominantly of a particular race, then the medications and the efficacy that we determine is going to be based on that subset of people, as randomized and as controlled as we try to make it. The problem is, if there are genetic and biological differences across different ethnicities, then we're not going to catch those in the clinical trial because you don't have enough people who have some of these enzymes activated, who have some of these loss of function genes that are in that clinical trial to determine if that medication is actually effective for those people. So representation is really important in clinical trials. But even before that, we have to understand what those biological differences are, so we can include those people in the clinical trials and make sure that we're targeting it towards those differences. There are some wonderful organizations that are really advocating for minority patients with breast cancer, such as Touch, the Black Breast Cancer Alliance, and Nueva Vida, which are in the Mid-Atlantic area here. Secondly, it's really important for patients to know that you have access to clinical trials at most academic centers. Here at Hopkins, we actually have 3 open triple-negative breast cancer clinical trials and a 4th one on the way. And these trials are evaluating everything from immunotherapy to standard of care and actually looking at some of the factors of obesity in triple-negative breast cancer. I do want patients to know that You can definitely learn more about clinical trials at Hopkins at hopkinsmedicine.org. And if you have any questions, you can reach out to us by email that you can find on that website, and we'll be able to direct you to our coordinators and see if you may be someone that may be a candidate for some of these trials. And I just think it's really important for patients to be advocates for their own health and understand that with a few extra clicks, you can definitely get a lot of the additional information that you may not be aware of, or you may not have been given in a recent visit that would be really important to the prognosis of your health.
And perhaps there is a glimmer of hope here, just knowing that decades-old practices are now being reviewed and there's a diversification of these tests and studies. I want to talk to you about being active in one's own health decisions. We go to the doctor, we know that we should ask questions, we know that we should do our own research and understand what we personally are going through. Given that foundational knowledge, what tests should women of color have in order to diagnose breast cancer, especially this very aggressive form, triple negative breast cancer?
There are no specific tests at this time that are unique to women of color. The diagnosis of any breast cancer, triple negative included, includes a mammogram and may include an ultrasound and MRI. If there is an abnormality on one of these imaging modalities, then a biopsy is ordered. Usually this is done via a core needle biopsy. So basically in the breast radiology suite, it's done as an outpatient. You would get a biopsy performed and they send this to a lab where a pathologist evaluates it. A pathologist is a physician that looks at the microscopic analysis of the tumor. And if it comes back as cancer, then they do the additional testing for the markers of the receptors to see if it is a triple negative or if it's an ER/PR positive, okay? Once that's determined, then you get referred to a breast cancer specialist such as myself to discuss the next steps in workup and treatment. So what does that next step include? If you are a patient with triple negative breast cancer, any patient with triple negative breast cancer diagnosed at any age is a candidate for genetic testing. So that's one thing that's really important to know. It's actually in our national guidelines. If you have been diagnosed with triple negative breast cancer at any age, it is important to get genetic testing. Why? Because of what we were just discussing a little bit about some of those genetic differences. But also there's a link between triple negative breast cancer and certain genetic mutations, particularly the BRCA gene. In patients with triple negative breast cancer, about 20% of them, or 1 in 5 of them, will have a genetic mutation in the BRCA gene. That's more than double the rate of BRCA mutations in the other types of cancers. The reason why that's particularly important to African-American women is African-American women with triple negative breast cancer, that rate of 20% can actually go up to about 35% of them with BRCA mutation. So genetic testing is very important. That's something that you should definitely advocate for if you've been diagnosed with triple negative breast cancer, if you haven't received it already. One little caveat that I want to add to that is, we talk about breast cancer a lot, right? But I do want to make sure that people understand that genetic testing is extremely important for multiple reasons, not just because of your breast cancer risk, but there are other cancers associated with these genetic mutations that are highly prevalent in breast cancer. For example, ovarian cancer, prostate cancer, and pancreatic cancer. So you're at high risk for these things as well with the BRCA mutations. So a lot of times that people don't realize that the genetic testing can not only save your life when it comes to breast cancer risk, but the risk of other cancers as well.
This could give you a jump start to figure out your treatment.
Correct.
So let's talk about treatments. What treatments are available for triple negative breast cancer?
One of the things whenever I answer this question is I try and make sure that people truly understand what triple negative breast cancer looks like. So I like to give you an analogy of a house that has keys with locks to open the door. In hormone receptor positive breast cancer, and also in HER2 positive breast cancer, we have developed many great treatments over the decades that, in addition to surgery, can treat breast cancer. For example, in hormone positive breast cancer, we have targeted medications like tamoxifen and aromatase inhibitors. These medications inhibit the cell from being able to use the estrogen and progesterone to grow. Okay. And for HER2 positive breast cancers, we have a medication called Herceptin, which also inhibits the cancer from using those molecules to grow. with those types of cancers, we have some keys that can be helped to use to open the lock. But now when we have triple negative breast cancer, you don't have any of those receptors. You don't have estrogen, you don't have progesterone, you don't have HER2. So it makes getting into that house and treating that cancer all the more difficult, as you might imagine. We have started developing medications to be specific, or what we call targeted therapies. That's where a lot of the research is focused currently on the treatment for triple negative breast cancer. So some of the medications that we have currently in use and on the horizon are medications that we call immune checkpoint inhibitors. These are medications that really help target a particular molecule, a protein on our immune cells, particularly our T cells, that normally helps keep them from attacking other cells in the body. So it really helps our immune system help fight the cancer. One medication that was recently FDA approved is called pembrolizumab, or Keytruda. That medication really blocks PD-L1, which helps boost the immune system to respond to breast cancer cells. You can really think about this as something that's helping your body being able to recognize these cancer cells so they can't hide.
And then fight it, recognize
And fight it, exactly. It's considered immunotherapy. It's really important because, again, a lot of the standard chemotherapy agents, we found that without those receptors and those targets, then they're not necessarily as effective in triple negative breast cancer. So we started developing new medications. So immunotherapy, and that medication, pembrolizumab or Keytruda, is one of them. We've also found that that particular medication improves survival in advanced triple negative breast cancer. Because I told you earlier, it's very aggressive. So a lot of times we're finding triple negative breast cancer at very advanced stages. So we have to have medications that can really treat it at that advanced stage. And we have found in studies and clinical trials that with pembrolizumab, adding the immunotherapy to standard chemotherapy agents can help patients with advanced triple negative breast cancer live longer than if they just received chemotherapy alone. Another group of medications are actually called antibody drug conjugates, or ADCs. These are another class of targeted medications that really combine the selectivity of antibodies. So antibodies are things in our immune system you develop to help fight a disease. It combines that science in addition to the potency of chemotherapy drugs, which kill cancer cells. You combine the two of them, that's where the drug conjugate, the word conjugate comes. It's a combination drug. They are being developed in the triple negative breast cancer setting. And one that got approved just February 2023, FDA approved, is a medication called Trodelvy. And that is a medication indicated for the treatment of adult patients with unresectable, local, or advanced metastatic triple negative breast cancer who have received 2 or more previous systemic therapies, and at least one of them were for metastatic disease. So it's not something that you're going to get necessarily right off the bat, but it's something for what we call like refractive disease, something that has not really responded to other therapies. A third group of medications that really have been getting developed and getting more and more science behind them are called PARP inhibitors. And these are medications that are considered immunotherapy and help our immune system destroy cancer cells. They are FDA approved for the treatment of HER2 negative metastatic breast cancer and in patients who have a BRCA1 or BRCA2 gene mutation. Patients who are triple negative are also considered HER2 negative because they're negative all the receptors. So currently we have 2 PARP, P-A-R-P, PARP inhibitors have been approved for triple negative breast cancer. The names of the medications, one is called olaparib, also known as Lynparza. So I'll spell that for you, O-L-A-P-A-R-I-B. And the other one, it's not as commonly used. The one that is more commercially used is the olaparib, but we also have another medication called talozparib. So it's T-A-L-A-Z-O-P-A-R-I-B. I'm probably pronouncing that not in the best way, but that's the name of the medication. I know. So we come up with great names, and sometimes pronunciation is always interesting. We really, like I said, have been making a lot of strides. Literally, these medications have been in the last 3 years.
Which is incredible news. I wonder, what do you foresee then with the unveiling of these different types of medication? Do you believe the survival rates will go up even in the more aggressive forms or stages of this cancer?
Absolutely. I mean, I'm definitely very hopeful. What we've found so far in those studies is that I talked to you about overall survival. Another thing that we look at is progression-free survival, which means that basically it's not necessarily going to cure your triple negative breast cancer, but it'll allow you to have a significant amount of survival time where your disease is not progressing. You will be able to live with breast cancer. I think it's really important for people to understand that ideally, yes, what we want to do is cure your breast cancer. That's the best possibility, right? Having what we call a PCR or a pathological complete response. That's when basically a patient undergoes the surgery, the chemotherapy, all the treatments towards their breast cancer, and then they have a complete response. When we relook at that tissue under the microscope, there's no remaining cancer. That's the ideal situation. That is a cure per se.
Yes.
Now, a lot of times we're not able to achieve that. So what's the next best thing? How do you live longer with breast cancer without it taking over your life? So a lot of these medications, what we've found in the trial so far is that they do allow for a period of progression-free survival. Now, these medications are new. A lot of studies that we look at when we talk about the overall survival, if we haven't even been on the market yet for 5 years, we can't really tell you what that 5-year survival rate improvement might be. So I think time will tell. We need some more time to be able to study these medications. But so far, we have a lot of promising results. And I am definitely hopeful, and so are other medical physicians and providers.
I want to talk about the external factors in our lives and what we can do to help ourselves to either better survive or prevent this form of cancer. Does diet, exercise, any other forms of lifestyle changes actually help you to not get this cancer, or that doesn't apply here?
One thing that's wonderful about medicine and science is we're always evolving. Things that we did 50 years ago, 100 years ago, we're not necessarily doing them now. And things that we knew then, we're learning more now. One of the things that, it's really important to understand are what we call modifiable risk factors and non-modifiable risk factors. Modifiable are things that you can change, and non-modifiable are things that you can't. We can't change where we come from, what our genetics are, and things like that. But there are some things that we can change. And particularly one of those modifiable risk factors includes obesity. Studies have shown that women who are overweight or have obesity have a higher risk of getting breast cancer than those that are at a healthy weight. Different socioeconomic statuses may contribute to this, like I alluded to before, in terms of access to healthcare and access to healthy foods. But the state of obesity can modify different cancer signaling pathways that directly impact the biological process of tumor growth, invasion, and migration. Some of these things can contribute directly to triple negative breast cancer in African American women. It is important to understand that obesity and being physically active, these are some modifiable risk factors.
Okay, thank you for that. I didn't know that, especially because we talked about the strong link between this cancer and your genetics. So it's good to know that there are things that we can do today that could help us. What happens? What should a woman know after a diagnosis? Of course, this could be a really traumatic, devastating time, not just for her, but for her community. What should she do after a diagnosis of triple negative breast cancer?
Usually that diagnosis comes after you went for your screening mammogram or you felt a mass, whatever it is, you had some sort of imaging modality done and a biopsy done. So a lot of times you'll be informed from the radiologist that did the biopsy that these were the results. And they'll usually at that point tell you, you need to see a breast cancer specialist. One thing that I always tell patients to advocate for themselves and discuss with their PCP or provider to make sure that they're getting referred to someone that treats breast cancer on a fairly regular basis. I treat it on an everyday basis. That's all I treat. I'm a breast surgical oncologist, but I happen to work at a large academic institution, and not everyone is going to have access to getting care at a large academic institution. Definitely discuss with your physician or provider where they think the best place for you to get your breast cancer care is. And you may not have the ability to transport yourself to a larger city. However, make sure whoever's treating you has access or communication to someone that may be a specialist in that area to maybe help guide or influence their treatment. Because if you are in an area that is not necessarily associated with a lot of clinical trials and these medications, someone may not be aware of the availability of these medications. So it's important that when you are diagnosed with triple negative breast cancer, you are seeing someone who's a surgeon. That can either be like myself, a breast surgical oncologist, or a general surgeon that does breast surgery. But also you want to make sure that you are seeing a medical oncologist. With triple negative breast cancer, the medical oncologist is the medical physician who is going to be aware of these new medications, who is usually very in tune with the release of these medications. So I learned of a lot of the release of these medications through my medical oncology colleagues. I also work at an academic institution. So I'm going to learn the day that that medication is FDA approved. Your PCP may not know about that information, but a medical oncologist would. So make sure that you are seeing the correct physicians for your care, which is going to include a breast surgeon, like I said, and a medical oncologist.
As you said, your primary care physician may not know about this, but an expert like yourself who's surrounded by other experts, you know when the news drops, when that
Correct.
research comes out.
Right.
Dr. Sogunro, what is the single most important thing that you would let women of color know about triple-negative breast cancer?
The single most important thing is that it does not wait for you to be ready. The biggest thing that I have seen in my practice is that a lot of times no one in my family has breast cancer. And I say to people, that number of 1 in 8 is irrespective of family history. That 1 in 8 is the average risk. That doesn't actually even take into account family history. Because then if you do have a family history, your risk is actually higher than that. So that 1 in 8 chance of developing breast cancer is in someone with no family history in the average population. And on top of it, breast cancer has to start from somewhere, and it may be you. The biggest takeaway that I can give my patients is to tell them that be in tune with your body and do your annual mammograms. Annual screening mammograms start at age 40 for the average risk woman. That is that 1 in 8 woman. If you have a family history, you have a genetic predisposition or any other high risk situation, then you often actually need to start your mammograms much earlier than that, sometimes up to 10 years before age 40. So it's really important to know your screening guidelines, see your PCP, right? Make sure that you have a PCP and follow up with them because they will be the ones to tell you, hey, you are 40. Okay, or your 40th birthday is coming up, I'm going to order your mammogram. It's really important not to say that I don't have any family history, I don't need to worry about it. We all need to worry about it as women. Because if you are in a group of 10 people, even if you're in line at Subway, right, there's probably going to be at least 10 people in that room, 10 women in that room or in that restaurant, then one of you is going to get breast cancer, at least. So it's really important to understand that. Don't let it be something that you are waiting to be ready for. The cancer doesn't wait for you, and it's very aggressive. So the minute that you are supposed to be getting your screening mammograms, you should. And secondly, do monthly self-breast exams. There's a lot of questions about this. Patients and people like, well, women don't really know what they're looking for and can cause some more confusion, and it can. But also it can help you diagnose a lump that may have been under your breast that you didn't realize was there the month before. So you may not know what you're feeling for, but you're going to notice if there's a change or a difference in your exam. And that could be the difference. Those few months that you notice that before your next mammogram is due could be the difference between life and death. Because like I said, this tumor grows very aggressively. So you could have had a normal mammogram in January of the year before, and the mass can be growing already later on that year. That was not seen on the mammogram because it wasn't there. It's very fast growing. It's important to understand that.
Timing is so important. And what struck me with what you just said is that you could be the first one in your family. Cancer starts somewhere. Dr. Olutayo Sogunro, I gotta say your title again. Everyone needs to know this. Assistant Professor of Surgery at the Center for Breast Health at Johns Hopkins Howard County General Hospital. I am so appreciative for your time today, your expertise, and I'm excited for everyone who will be able to listen to this and get the knowledge that is necessary. Thank you. Thank you so much for your time today.
Thank you for having me. It was a pleasure.
And thank you everyone for joining us today for this special podcast, Triple Negative Breast Cancer in Women of Color, A Woman's Journey. Would like to thank Dr. Olutayo Sogunro. This activity is supported by an unrestricted contribution from Lily. I hope you will join me next week for the second podcast of this very special podcast series, A Journey for Women of Color. Next week's podcast, Sickle Cell Anemia, will feature another Johns Hopkins expert, Director of the Division of Hematology, Dr. Robert Brodsky. If you're looking for more content that is very vital to your health, tune in to next week's podcast. Also, check out A Woman's Journey's website, hopkinsmedicine.org. A Woman's Journey for information about upcoming free webinars. Subscribe to our Insights That Matter podcast series and sign up for our monthly email. Have a great day, everyone.